Hello everybody, welcome on this webinar on the EULAR 2025 recommendation for familial Mediterranean fever. I am Sophie GEORGIN-LAVIALLE from Paris Tenor Hospital.
And I am Véronique HENTGEN from Versailles Hospital, and we are both working in the French Reference Center for Autoinflammatory Diseases. And
this webinar is on the account of the French Network for Autoimmune and Autoinflammatory Disease, FAI²R. Familial Mediterranean fever is the most common monogenic autoinflammatory disease worldwide. We estimate from 5,000 to 10,000 patients in France and approximately 100,000 patients worldwide. However, many specialists, pediatricians or adult doctors, are not totally familiar with the management of this disease. That's the reason why EULAR proposed a recommendation. They were previously done in 2016, and this is the update for 2025. Our objectives were to provide evidence-based recommendation updated from the ones of 2016, and they are intended to guide rheumatologists, internists, pediatricians, and other healthcare professionals to the treatment and monitoring of familial Mediterranean fever. What was the methodology? It was quite a classic methodology for EULAR. A multidisciplinary group was set up, including doctors, rheumatologists, internists, pediatricians, nephrologists, therapists, physiotherapists, 2 methodologists, and 2 patient representatives, all of them from Eastern Mediterranean region and Europe. Several systematic reviews have been carried out on the pharmacological treatment of familial Mediterranean fever and its complications. And we also revised the previous recommendation to take account of updated data and new levels of evidence if they have to be incorporated. Then we finished on an agreement of the recommendation by a Delphi survey.
The results were 4 overarching principles and 12 recommendations. The degree of agreement was very high, with in all of the cases, an agreement of over 9 of 10. One of the main stones in our recommendations was the improving therapeutic adherence. It's really very important, and that's why it's in several recommendations. Finally, we defined also a set of priorities, quality indicators, and other implementation strategies. The overarching principles were that FMF is indeed a complex clinical and genetical disease. That's why it requires expertise in diagnosis and management. The treatment objective will be to control the attacks and subclinical inflammation to prevent associated damage. So it's the first time that we have treat-to-target strategies in FMF. FMF requires also a lifelong management, including long-term prophylaxis with colchicine. That's why the adherence to treatment is really the cornerstone of FMF management and should be assessed in every outpatient consultation we have with our patients. Finally, the last overarching principle was that the care should be patient-centered, so that it's really needed to promote a good quality of life and encourage health and well-being. We have to work with our patients. The first 3 recommendations were about diagnosis and treatment. The treatment with colchicine should begin as soon as a clinical diagnosis is made. We should not wait for the genetic confirmation, even if we should do it. However, the treatment should begin as soon as the clinical diagnosis is made. The colchicine may be administered in single or divided dose, depending on compliance and tolerance of our patients. And in adherent patients, the persistence of attacks or subclinical inflammation is an indication for increasing the dose of colchicine within the recommended range. For children, that will be 2 mg per day, and for adults, it will be 3 mg per day.
Here is a representation of CRP levels during crisis. You can see there that the CRP gets elevated and is normal during a flare of the disease, but the target is that CRP becomes below 5 milligrams, or the normal of the lab, in between attacks. Our objective in those recommendations is to be aware of the target in between attacks. Here you can see we expect the CRP to be lower than the normal rate, and here it's not normal. It's between, for example, 6 and 25, and the objective is to decrease this CRP in between attacks to normalize it in order to prevent chronic complications such as AA amyloidosis. The fourth recommendation is about patients that do not respond adequately to the maximum tolerated posology of colchicine, and then additional treatment should be considered. To date, the highest level of evidence for this additional treatment consider those targeting IL-1, and we have 3 different treatments worldwide. We have anakinra, we have canakinumab, and in some countries we have rilonacept. The fifth recommendation is about patients displaying chronic inflammatory musculoskeletal condition associated with FMF. Most people can display sacroiliitis. The 2 main classical conditions are axial spondyloarthritis without HLE-B27, so it's negative. Those patients associated with patients with psoriatic rheumatism may require biotherapy targeting TNF-alpha, so TNF inhibitors. A third condition, which is less frequent, is patients displaying coxofemoral involvement, which is called coxitis, hip involvement. And in this case, we mainly provide IL-1 inhibitors for patients.
The recommendations 6 and 7 were about colchicine. So response, toxicity and adherence to colchicine must be monitored regularly, more often at the diagnosis and when the disease is uncontrolled. The minimal follow-up for a patient with FMF should be twice a year. So if it's not possible to see these patients every time in an expert center, we should work with the family physicians. The 7th recommendation was about colchicine intoxication. As this can be fatal, an intentional or accidental overdose must be carefully assessed every time we see our patients.
The 8th recommendation was on the biomarkers, especially in AA amyloidosis, which is inflammatory amyloidosis secondary to the deposition of serum amyloid A protein. In this case, the aim of the treatment is to totally normalize SAA measurement in the blood. And if SAA is not available in the country, we have to monitor CRP, especially ultrasensible CRP.
The 9th recommendation is about patients who should be treated with EL1 inhibitors or other biological DMARDs. Indeed, even if in these patients the doses should be optimized, that means that if the patient has still clinical signs, the treatment must be up titrated, but in the event of remission, a gradual reduction and the discontinuation of the treatment may also be considered. That means that the patient has to continue during all this time colchicine treatment, and that biological DMARDs will only come as an add-on to the treatment to colchicine.
The 10th recommendation is about fertility and pregnancy. The main message is that colchicine should be taken during pregnancy and also breastfeeding. And for patients that want to have a good fertility, they should take their colchicine. Also, a second point is that amniocentesis is not currently recommended for FMF.
The 11th recommendation was about the attack management. During an attack flare or FMF attacks, the usual dose of colchicine should be maintained, and the symptomatic treatment such as NSAIDs is recommended. However, no morphine derivates or corticosteroids to treat inflammatory attacks. Indeed, patients who have very severe attacks should only should have an assessment if their disease is in the treat to target strategy. If not, colchicine should be adapted. If the treatment is correct, an add-on with an on-demand treatment could be seen.
So do not double the colchicine posology in crisis.
And finally, the last recommendation was about standardizing patient care and research. So during every outpatient clinic visit, a minimum set of monitoring criteria should include measures of clinical activity of disease, for instance, frequency of attacks over 3 months, and the physician's assessments should include a patient experience. So we have to ask our patient how he feels about his disease, and finally should include a biochemical marker, for instance CRP. So this was the flow chart we had done with the group. When you have an FMF diagnosis, you have to start colchicine and you have to implement a treat to target strategy, increase colchicine dose till the maximal dose till you have reached your target. If you are not able to reach your target, you will add a biological DMARDs, preferably an anti-IL inhibitor, and then when you go to clinical remission, you could also consider again the tapering of IL-1 inhibitor after 6 or 12 months. So again, you have to titrate the biological DMARDs exactly as the colchicine to come to your treatment target.
There is a lot of research agenda. We will not go through all of it, but work will be done in the future to better assess the genetic diagnoses, to improve the perfect management, to assess the complication, especially liver involvement, and also provide tools for patients' education.
So as a conclusion, we have a set of widely accepted recommendations. We have numerous A or B grade proofs, and the experts often agreed on items with a slightly lower level of evidence. The experts came from all Europe and also of countries with high FMF endemicity. And here is our group who discussed about these recommendations.
And here you can recognize César Ozen, the leader of the recommendation. And here César Ozen with us, and the president of the International Society of Autoinflammatory Disease, Hélène Lachmann, and the methodologist. So we thank you very much for your attention.
And see you soon.